Hi everyone, welcome and thank you for joining us for today's National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living and hosted by the American Society on Aging. We'll be getting started shortly. The slides for today's presentation are available under the tab on your screen labeled Resources, and under the tab labeled CE Application here, you'll find information on how to obtain CE credit for this event. You'll have 60 days to complete a continuing education application, and it may take up to 30 days from the date of your application in order for us to process and issue your CE credit. If you are not logged in directly to this webinar, that is if you're watching as part of a group and did not log in using an individual confirmation URL, you will not be eligible for continuing education credit because we have no way to track your online attendance. If you'd like to receive CE credit, please be sure you log in using the confirmation URL you received after individually registering. If you have questions during the presentation, you can send those at any time using the questions box, and we'll save those for the last 10 to 15 minutes of today's program. Now I'd like to welcome Sari Schumann of the National Alzheimer's and Dementia Resource Center. Hi, Sari.
Thank you, Betsy, and thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Complex Care Management for People Living with Dementia. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi everyone. I want to thank you very much for taking the time out of your busy schedules to join us for this important webinar. I want to thank Sarah Dulaney and Lori Resnick for being willing to share their wisdom with us. I also wanted to take this quick opportunity to build awareness of a grant opportunity that is open for our Alzheimer's and dementia programs. The slide on the screen has the name of the grant opportunity and the opportunity number. It just opened. It is open for 60 days for applications. There's an opportunity for states and an opportunity for communities. So please, if you're an existing home and community-based service provider that's providing dementia services, please take a look and see if it's something that your organization might be interested in and able to apply for. And if you're a state unit that is designated to deliver services to older adults and do dementia work, please also look at that as well. And with that, I will give you back to Sari and we can start the show.
Thank you so much, Erin. So as you heard, today's presenters are Sarah Dulaney and Lori Resnick. Sarah Dulaney is a geriatric clinical nurse specialist with expertise in dementia at the University of California, San Francisco Memory and Aging Center. Since 2014, the focus of Sarah's work has been on helping to develop, implement, and evaluate the care ecosystem, an open-source chronic care management program designed to improve outcomes for people living with dementia and their families. We also have with us today Lori Resnick, who has over 20 years' experience working and supervising geriatric case managers, and she is dedicated to helping clients navigate complex systems of care and leverage services to sustainable solutions for aging safely in place. Her current role at OneGeneration allows Lori to oversee the implementation of their complex case management program. She is focusing on addressing the needs of adults with intellectual and developmental disabilities who are at risk of or have Alzheimer's disease or dementia. At this time, I will turn the floor over to Sarah Dulaney to start our presentation.
Thank you, Sari, and thanks everyone for joining us today and being interested in this topic. I want to acknowledge our funders, which include the Administration for Community Living, and I'll just tag on to Erin's encouragement for community service providers to pursue that funding. They're great partners to work with. Our objectives for today are to discuss 2 reasons for greater integration between medical and social care services for people living with dementia, and then demonstrate 3 reasons why people living with dementia require highly accessible, specialized, and flexible services. This is a quote from Chris Callahan, a geriatrician at the University of Indiana who's been an advocate for people with dementia for many years. And he's encouraging all of us to think about reconceptualizing how we think about and pay for care for this population. As if you work in this field, you know that currently health systems and social service agencies, community organizations, we sort of are a patchwork of services, and there are a lot of gaps in care that are we really rely on family members to fill, and families are not prepared for or supported in filling these gaps in care. The few programs that do exist, both in health systems and community organizations, are really, they struggle to sustain themselves with grant funding and philanthropy, and this, model is not sustainable, and it really leads to inequity. So, the availability of these services are not widely available in this country, and that's a problem for this population. Why is dementia care different? Unlike other diseases, dementia takes away a person's autonomy. It's highly stigmatized globally and poorly understood by laypersons and professionals alike. People living with dementia, their care spans health and social care systems and lasts for years and evolves over time. So it really requires, more holistic care and continuity of care over years. And as I mentioned before, the bulk of this care is provided by families who are not trained or supported in this work. So as already mentioned, my main role has been working with the care ecosystem, which is a model for chronic care management for dementia, where the primary point of contact for a patient and caregiver is a care team navigator, who's a lay person that is trained and supported by a clinical team that includes a pharmacist, a nurse, and a social worker. And the program is designed to partner with people from diagnosis through end of life, bridging community-based services and healthcare, and helping people navigate all of the stages of care. We were originally funded by a Centers for Medicare and Medicaid Innovation Award, and we've implemented a randomized control trial that's still ongoing. In the first 12 months, and compared to the usual care group, people in our intervention group had improved caregiver well-being. That's lower depression on the PHQ-9 and lower burden on the Zarit burden scale, improved patient quality of life on the quality of life AD, and actually reduced emergency room visits in 1 year. And this was a study of over 700 dyads across the state of California, Nebraska, and Iowa. We're not the only model of care out there. This website down below that's maintained by the Ben Rose Caregiver Institute has, hundreds of dementia care programs. I mentioned a few here that have really been influential in the work that we do. The UCLA Dementia Care Management Program that's delivered by nurse practitioners, partners in dementia care, that has similar navigator roles as we do, as well as the Indiana Aging Brain Care and Johns Hopkins Maximizing Independence at Home. Those are care management programs that work with patients and caregivers. And then there are caregiver-targeted support and education programs that have also demonstrated efficacy in improving outcomes for caregivers, and we know that improving outcomes for caregivers has a direct impact on the persons that they support. So I encourage you to use this resource to help find tools to implement evidence-based programs. There are, in this review article, they looked at over 200 dementia care interventions that have been tested in research. The unfortunate thing is that few of these programs have been translated, and they're not accessible to the bulk of dementia family caregivers in the United States. And these are, there are a lot of barriers to scaling these kinds of interventions, and programs like the Administration for Community Living funding sources for these kinds of programs is an important way to make these more accessible. For our program, we've developed tools to help organizations implement our model, we have on our website freely available toolkit, our protocols, our educational materials, and even our training program, which we use Canvas. You have to log in, but it's freely accessible. So anybody who wants to use or adapt it for your setting, that's where you can go to get more information. For the rest of my part of the presentation, I'm going to talk about brief cases that I think demonstrate the reasons why we need more integration and more personalized care for this population. So these are real cases that have been changed for privacy. So the first one is a confused older male who's found on the highway in the middle of the night by police. He said he was walking to his sister's house and he's taken to the emergency room. Dementia is on his problem list in his medical chart, and they do a delirium workup, and they don't find any underlying cause for this confusion. He's treated for minor abrasions on his knees and starts asking staff where he is and saying he wants to go home. They're able to contact his wife, and she comes to pick him up. She appears overwhelmed and says she's not sure what to do. They have a social worker or a discharge planner meet with her, and she acknowledges that, she needs more help, but she's concerned about their ability to pay for it. And the discharge planner's advice was basically saying that, you are not able to provide the level of care that he needs at home, and we recommend that you place him in secure memory care, which is not terrible advice, but really this person didn't have the time to assess, their ability to pay for those services, and in this case, they really didn't have the resources. So if that's the only advice that you give, then it kind of counts as nothing because they can't afford it. So what else are they supposed to do? There's a lot of research, kind of a depressing amount of research that shows that older adults with functional deficits, if they don't have the level of support that they need to address their IADLs and ADLs, they have increased hospital use. And similarly, when caregivers are not supported and they have higher level of strain, or they're helping with, more tasks, providing more hours per week with less support, there's increased ED use. An evaluation of our own cohort in the care ecosystem, caregivers with higher depression, was associated with increased ED use in the patients living with dementia. And similarly, in an important group that falls through all the cracks are those living alone with cognitive impairment who also have higher ED use. So in this next case, we're going to talk about an older man with memory loss, anxiety, and chronic pain who keeps calling his doctor for more medication refills for his pain medication. And he's taking opioids as well as benzodiazepines for his anxiety. And he complains that the medications are not strong enough to control his pain. He lives alone, and his mobility is severely limited by pain in his legs. So you can imagine, being the provider, what your concerns might be. The combination of benzodiazepines and opioids can cause death, and someone with memory loss may not remember if they took their medications, and could easily have an accidental overdose. So this demonstrates, why medical health care and, the prescribers need social care, and we need a bridge between that, particularly for people living alone who don't have caregivers that are able to supervise their medications and manage them for them. The loss of ability to manage medications and appointments impacts health, and this is, these IADLs, as they're called, instrumental activities of daily living, are the first functions that are typically affected for people with dementia. About almost 50% of them have difficulty with these kinds of functions, and 72% reported not receiving any help. So that's a major gap that's going to impact their health. Medication adherence among this population is as low as 17%, and they're also more likely to discontinue medication before the end of treatment. So, for people taking antibiotics to treat an infection, this could mean their infection is not resolved. And this non-adherence is associated with an increased risk for hospitalization or death. So I think social programs, designed to support people with dementia, focusing on medications and medication adherence is an important thing to focus on. So the next case is an older woman who lives alone and is at risk for being evicted because of accidentally starting fires in her apartment. She honors her ancestors by lighting candles at an altar on the floor of her studio apartment. Her communication is limited by severe hearing loss, language barriers, and advanced dementia. And the navigator working with her came to our team. We have weekly meetings where we talk about challenging cases, and she was just feeling discouraged, saying, I'm not really sure how to help this person. I can't really tell what she thinks, understands, or wants. And I think this is when we don't have continuity of care and continuity across integration across health and social care systems. If people don't have family, if they're estranged from family and they don't have someone who does know them, who can help advocate for them, dementia, they're not able to fill in the gaps for us, so they become kind of a mystery, and it can be really challenging to try to personalize care when you don't have that context. So I think, this is why I think it's really important to have programs that start, when someone is still able to share their story, when we still can have, learn more about their narrative and history, so that we can support them better as their disease progresses. I mean, certainly we can help prevent fires and eviction in this case, but ongoing, personalizing her care will be more challenging. So I think for the people delivering this care, it's important to have our own coping mechanisms and recognizing when we do feel a sense of helplessness or hopelessness, because we're not going to be able to help people effectively if we feel hopeless ourselves. And this is from an article by a palliative care team that practice Buddhism. So recognizing your reaction and embracing your reaction, or recognizing that it's normal, and then taking care of yourself. So whether that's some kind of exercise or walking or taking some deep breaths or journaling, whatever you need to do to kind of clear your mind and get to a place where you feel more refreshed and can take a new perspective. I think one of the things I really appreciate about our care ecosystem model is the team-based approach, because when we run out of ideas, we have a team that can help us see things in a new way. And I think that is particularly important when you're working with this kind of population. So that's just a self-care note for the care managers out there. And I also want to recognize that person-centered dementia care takes time and skill, and these are challenges and opportunities that will be familiar to all of us working in this field, that recruitment and retention of a dementia-capable workforce, financing this work, interprofessional education and training for staff, and translating and implementing effective dementia care programs. So I think, these are the areas that we all need to work on, and the ACL can help fund this kind of work, which is important. Fourth case is a woman with memory loss who's been losing weight and complaining of tooth pain. So always when we see weight loss in dementia, we want to think about any oral care concerns that might be contributing. Unfortunately, she's afraid to go to the dentist, and she's already missed 2 appointments. She did go to her last dental visit with a navigator, but then left when the hygienist tried to clean her teeth. She got really scared, and she doesn't want them to touch me. She has a history of trauma and very afraid of the dentist. So as we can see, standard of care excludes or sometimes harms people with dementia. I think, the default would either be to say that she's refusing care, therefore we can't provide dental care, or to go straight to general anesthesia for oral care. And I don't think general anesthesia is wrong, but if you think about how children's hospitals or pediatric dentists might adapt their setting, or if dental hygienists could make home visits to help clean people's teeth, if we had kind of more integration in between these programs, that we might be able to accommodate people like this woman. I also think it just demonstrates that, I've heard from family members too, we have canceled visits in our clinic because some days are good days and some days are bad days. And on a bad day, you just can't force it with this population. We really have to be flexible and adapt. And so I think we're currently largely delivering low-value care to people living with dementia, and there's a lot of opportunity for being more personalized and flexible and adapting for this population. This is a quote from a woman living alone with dementia. Elena Portocolone is a qualitative researcher. I love her work. She interviews people living alone with cognitive impairment about their experience. And this woman is saying, I'm in real pain right now because I don't have a place to go during the day. If they don't let me come back, what will I do? I mean, really, what would I do? What am I going to do? This woman had cognitive impairment as well as severe depression, and the day program that she really relied on for her social support and engagement had told her that she couldn't come back because she was too depressed, and she was talking about suicide, and it was bringing down the other people in the program. And I think, these people who have, mental illness plus dementia or dementia with behavior symptoms, I think this is the population that we have to try our best to serve, and really our programs, not just to serve the sweet ladies that aren't interruptive or disruptive and kind of sit there and participate, but the people who really need it, who are really suffering and not fitting in our traditional models of care. In this case, the patient had a caregiver. He lived with his daughter. He had cardiovascular disease and had recently been prescribed an antibiotic for pneumonia. He has paranoia and had previously refused to take medications until they had his medications delivered in sealed bubble packs from the pharmacy, and that only then would he take them. But since this new antibiotic is temporary, the pharmacy won't dispense it in a bubble pack. They dispense the bubble packs every month. And so he's been missing doses because he's refusing to take them, and his daughter is kind of freaking out that he's going to die, and she's telling him he's going to die if he doesn't take his pill, and he won't listen to her. So we were able to find strategies for getting him to take most of his pills, and his his pneumonia was successfully treated. But, his daughter was at the point where she was, the pharmacy wouldn't give her an empty bubble pack so she could transfer them to a new bubble pack. She tried to buy bubble packs on her own to fill them. And, it seems like such a little thing, but it became such a conflict for her and was affecting her father's health. I will just make a plug for bubble packs that, they're inconvenient to set up originally, but particularly for people with problems with medication adherence or who refuse medications, it can allow people with cognitive impairment more independence in managing their medications. So in summary, we've discussed the two reasons for greater integration between medical and social care services for people living with dementia, mutual understanding both on the part of health systems and social services so that we have realistic expectations about the availability and utility of their services, and then ways that collaborative efforts can reduce harm for patients and their families. And Lori, I think, will present their model that I think their collaboration with health systems has had good outcomes. And then demonstrating 3 reasons why patients living with dementia require highly accessible, specialized, and flexible services. Cognitive impairment limits their ability to navigate and enroll in programs and services. I think that's obvious. We need staff training so that we can learn how to accommodate and support people with atypical behavior symptoms. And our programs and services need to be personalized and able to accommodate a full spectrum of symptoms and needs. I have some slides that have resources that are freely available online, as well as a long list of bibliography if people are interested, and my contact information. So thank you for your attention. And with that, we'll hear more from Lori about her program. Thank you.
Okay. Thank you so much, Sarah. That was a really informative presentation, and I would also like to thank those who invited me to participate in this webinar. It really is an honor and a privilege to be here. I am the program manager overseeing our Alzheimer's disease and related dementia services at OneGeneration. Our mission is to enrich the lives of seniors, children, and families throughout the diverse community. And I'm going to talk more about the Feet on the Ground program that we've implemented. For my presentation, I'll be giving an overview of our community-based case management program, and this will include how to identify and prioritize client needs, understand, address the barriers of care, and learn how to create a social service safety net and understand the importance of relationship building and leveraging resources. So a little bit about OneGeneration. We're positioned to provide complex case management. We've been serving the community since 1978, and we started as a little storefront center in the San Fernando Valley. And as the demographics have changed and the seniors' lifespans have increased, we've expanded our services to meet the continuing needs of those we wish to serve. So we have a multi-purpose senior center, enrichment center, where we offer activities, congregate meals, home-delivered meals, traditional case management, grandparents as parents, a weekly farmers market, and as Sarah discussed, an adult daycare and adult day health program, which has been really important for seniors in our community, for those with cognitive impairments. What's very interesting about our program, in 1994, we added a child care component. We have child care on site too, and when we were open pre-COVID, the children and the seniors met in our adult daycare center daily to have programming, and this has been mutually beneficial for our seniors and for our children as well. So the need. The need in our community is great due to the large size. LA, okay, I'm going to speak a little bit louder into the mic. Due to the need, LA County is very large. The Department of Public Health and Social Services has divided the region into 8 SPAs, or 8 service planning areas. OneGeneration is located in SPA 2, which you can see serves the largest population of all in the area. We have over 2 million individuals, and of those, over 310,000 are over age 65. 42% are Hispanic. 20 live in poverty. 41% have less than a high school diploma. Okay. In 2018, OneGeneration received a 3-year grant from the Administration of Community Living with the goals to provide training and education, promote a deeper understanding of Alzheimer's disease and related dementia, reduce isolation of older adults in our community, and increase availability of respite care. So, how will we do this? We partnered with Dignity Health Northridge Hospital, the Alzheimer's Association of Southern California Southland Chapter, and Cal State University Northridge. Through this grant, Dignity Health is providing our health worker training aimed at educating social workers, nurses, students, and other allied health professionals on Alzheimer's disease and related dementia. The Alzheimer's Association is providing educational opportunities through the Savvy Caregiver curriculum and support to caregivers with those with Alzheimer's disease and related dementia, as well as training professionals at community-based organizations that work with adults with an intellectual and developmental disability on identifying Alzheimer's disease and related dementia. OneGeneration was responsible for integrating adults with intellectual and developmental disabilities who may have Alzheimer's disease and related dementia into our adult daycare program, offer monthly Saturday adult daycare, and develop and provide more intensive case management to meet the needs of seniors in our current and expanded service area. So, what is case management, you may ask? Many of you know, but according to the Case Management Society of America, they say that case management is a collaborative process of assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services to meet the individuals and families' comprehensive health needs through communication and available resources to promote patient safety, quality of care, and cost-effective outcomes. So that's really quite a mouthful. So to boil it down, when you look at the clients with moderate to severe Alzheimer's disease and related dementia that we serve, the main component that we found in creating this program is collaboration through relationship building with other community-based organizations that serve older adults. So we'll touch more on that later on in our presentation. So if you remember the movie Field of Dreams, you may not be old enough, but it was stated if you build it, they will come. So we needed to create and market a program that was not only beneficial for our potential clients, but we really needed to have buy-in from the community. So our established criteria with ACL, we are very fortunate that they gave us the freedom to also create a program that really would address the needs of those in our community. So to work with those 60 plus, however, we were flexible, and this is important to know, that if individuals under 60 showed signs of early onset dementia or had a cognitive impairment, we were flexible enough to include them in our program. Those living in our SPA 2 service area and our expanded service area, that included San Fernando Valley, Santa Clarita, and Antelope Valley, were low to moderate income, but we did not eliminate people for any reason, and they were willing to sign a participation agreement and consent to the evaluation process. In addition to myself, we hired 2 part-time field-based case managers and reached out to key stakeholders in our community. We targeted affordable and Section 8 housing, and we were not only passed out flyers but went door to door, but what was very important was we met with landlords in those management companies to not only discuss our services, but we also educated and trained them on the warning signs of dementia in their residents. This could be repeated phone calls to their office, missed rent payment, changes in emotional behavior, or physical appearance. We found that oftentimes the managers are at a loss of where to turn and help for services, causing residents to be evicted or institutionalized prematurely. So we made sure that they saw us as a resource and they could depend on us and call us at any time with any questions. In addition to this, we marketed to discharge planners in local hospital and geriatricians in the community. So creating a referral stream. We created a referral stream through collaboration with other multi-purpose senior centers in the area, and this was instrumental in getting our cases and case findings. We marketed our program in such a way as to offer additional hands-on assistance. We weren't taking their cases away. We were offering to help them with some of their more difficult clients. In the San Fernando Valley, there are 600 older adults that are being case managed, which is a lot. Because of this, we offered our services as a way to do the heavy lifting and provide support to not only the most challenging clients, but also to co-manage clients with them and work at their centers. So leveraging our resources through the Department of Aging, OneGeneration, and other multi-purpose senior centers offer transportation, nutrition services, in-home assistance, wellness, education and screening, social and recreational activities, and case management. If clients did not live in our regular service area, we offered our complex case management services to the other multi-service centers, explaining how we could help. We offered to have the case management aspect of the case transfer to our program so they could still use their nutrition services, all their other services offered. But we said that we would do additional things such as scheduling necessary appointments, accompanying clients to regular doctor visits, weekly visits to assist with bill paying, grocery shopping, securing government assistance, available for daily support and reassurance. Basically, we said we'll take on the day-to-day needs of these clients while partnering with their local senior center for their contracted services. Okay. Our initial intake, we always talk about what is the dream and what actually occurs. So when enrolling new clients or transferring a client from another program, what our initial intake included the quality of life, QOL-AD, patient health questionnaire, 4PHQ-4, a home environment and safety assessment, assessing IADLs, and ADLs, the risk for depression, overall mental status. But most important for us was to determine their formal and informal support network. This could be as simple as talking to the mailman or anybody in their neighborhood. It should be noted that the primary goal for us was to establish the trust, and many of these clients are cautious, hesitant, or paranoid, and a stranger they assume is going to take away their freedom. So if this was the case, we really scaled back on some of our intake questionnaires. For the purpose of this grant, we had the QOL and the patient health questionnaire, but we would often wait until the client might feel a little bit more comfortable with us before we talked about that. Our anticipated outcomes, with that in mind, we wanted our clients to experience an increased quality of life and a reduction in depression, isolation, and decrease in hospitalization. So who are the clients that we served? Who is our typical client? They experience a form of dementia and or paranoia. They're socially isolated. They have limited formal and informal support network. They have limited financial resources. They have not received adequate health care. Often they haven't seen a doctor in years. They have been unable to access government benefits, and the key thing is they often don't want our assistance. So how do we work with them? As Sarah discussed, we really have to focus on person-centered care. And to create a case management care plan, as many of you know, is the easy part. So to implement it is another story. So for us, we realize that it's critical that we build and establish trust with these clients, and sometimes that's visiting them several times before we even touch on a care plan. This can be achieved by focusing and valuing our clients' strengths. So we include them in the care plan and continually share status updates with them. And this is basically having conversations with them and going back with them and saying, you know, remember when we discussed this and that? We're going to include that in our care plan, and if there's ever a change, we let them know so they don't feel that we're doing things behind the scenes on them. It's essential to have our clients buy into the plan and realize that we're helping them to achieve their goals. So what are their goals? However, a lot of these clients are more at risk for fiduciary abuse, and it is a constant tightrope and balancing act that we're doing between helping them with their independence and working to keep them safe. So because of this, it's been imperative that we work with others in the community that have a variety of disciplines in working with older adults and those with dementia. And Sarah also spoke about that as well. So this is we created a social service safety net. So how do we do that? We were fortunate to partner with the local elder abuse team LEAP EMDT, and the project is funded through the Office of Victims of Crime. So the team consists of professionals from a variety of disciplines who have experience and expertise in Alzheimer's disease, forensic accounting, geriatric and mental health, legal services, and care management. So this team was instrumental in assisting our clients. We meet monthly to discuss cases, and over the past few months, we've brought many of our clients to the team, and we're able to receive seamless referrals and follow up to legal advocacy, capacity assessments, medication evaluations, and through this partnership, we were able to deepen our relationship and have a reciprocal relationship with APS caseworkers that cover our service area. So in looking at our client demographics, what's really important to know is if you look at the breakdown with women being slightly higher than men, what's most notable is that 44% of those that we work with live alone and have no identified caregiver. So these are the clients who obviously took up a lot of our time. In looking at this, our services for the most recent 12-month reporting period, we can break down the services into the first 6 months, which was pre-COVID, and the second 6 months, which was throughout COVID. You can see that the number of hours pre-COVID was about 16 hours of case management per month per client. Throughout COVID, during the second 6 months, this was reduced to about 4 hours, but this dropped, and we can attribute this partially because of our inability to do home visits, but also we did continue to see those most at risk and isolated at home. But another variable is that many of these clients already had services in place prior to the pandemic. We were able to get them stable and their day-to-day needs were met. But also a lot of them had family caregivers who were returning home because they were forced to work from home. So they were able to take care of some of these services for them. In our measurable data, in looking at those that we served pre-COVID, we were able to see that participants that completed them, there was the PHQ-4 and the QOL, there was an 11.1 reduction in stress, and there was a 6.2 increase in quality of life. However, in looking at measurements of our clients throughout COVID, the 20 that completed the 6-month follow-ups, we can see that there was a 6.6 reduction in stress and a 6.2 increase in quality of life. But for the 7 clients who completed the 12-month follow-ups, there was an 8.3 reduction in stress as opposed to the 11.1 6 months prior, and a 7.7 decrease in quality of life as opposed to the prior 6 months when there was no COVID and there was a 6.2 increase. We can attribute this or may be able to the continued deepening of social isolation these clients are feeling, the progressive nature of Alzheimer's disease and related dementia. But as you can imagine, this has been extremely challenging as many of our clients need hands-on services. We've scaled back on our home visits, but we still have continued to see the most vulnerable, and we have used our home-delivered meal programs and other people on the ground, feet on the ground, to let us know what has been happening if they've noticed changes in our clients. Okay, so we have continued to provide services during the pandemic. We have offered telephone reassurance calls, grocery shopping services, arranging and accompanying our clients to doctor's appointments when necessary, Zoom classes, and we've had vaccine clinics at our center. To date, our facility has been able to vaccinate over 500 older adults, 65 and over. We have a second vaccine clinic going on right now as we speak, and we have a first vaccine clinic that will be taking place on March 17th. In addition to meet the needs of our low-income clients, we have created a drive-through food bank, and we've been able to redistribute 250,000 pounds of food every month. So I would like to, I know we do not have a lot of time, so I'd like to briefly go over a vignette that we have. We have a 79-year-old single white male who had no dependents, and he lives in a small single apartment with no services or social support. Initially, we met him when he walked to our center that was 2 miles away from his house. He was unkept. He had his jacket was tattered and had holes, and he was weepy. He was an established artist and complained that he had signed a paper allowing his landlord to get his artwork when he died. We did a home visit the following day and did a comprehensive assessment. He showed signs of paranoia, stating that his landlord was stealing. We ended up, his paranoia escalated, and he was more accusatory. We were able to help him stay at home, and he recently went to the, and his initial intake, he's declined dramatically. What we had basically done several months ago, he arrived at our center and was very combative. We stabilized him during the pandemic, but he's really declined. We had to have him put him on a 72-hour hold. He was discharged to a skilled nursing facility where he continues to reside, but we're helping him to get into an assisted living facility. He's been hospitalized several times, and our case manager has worked with a physical therapist to get him up and walking, to help him so he can continue to live independently and be transferred to an assisted living facility. So one of the things that we did, I will briefly go over this, we implemented home-delivered meals. We accompanied him to the bank to arrange alerts and determine his savings. We helped him with a wander bracelet. We advocated for him when he was on the 72-hour hold. We arranged a capacity assessment so we could have permission to close up his apartment. We closed up his apartment. We assisted in securing a durable power of attorney. We transferred, we had his artwork assessed by an appraiser to see if funds from that could go to his care, and we are currently helping him to transfer to the assisted living, to an assisted living facility. So basically, what we have learned is to establish trust and the nature of this work. Because there's such a high turnover in staff, we have worked with our clients to identify with OneGeneration as who they, as opposed to their case manager. And we also have, when we have our home-delivered meal drivers, they are always wearing OneGeneration shirts. We visit our clients, and they know that OneGeneration is a safety net to contact. We also have learned that what we need to do is just to really be patient, be flexible, and be creative, and always practice patience and tolerance. So with that, I know I sped through it, but thank you so much. And if you have any questions, we can answer them now.
Thank you so much, Sarah and Lori, for your great presentations. Excellent information shared, and we do have questions coming into the Q&A chat pod right now. So I will start with a question that came in that both of you can answer, asking about how you worked with those who did not have identified caregivers during your work. Sarah, do you want to start and talk a little bit about that?
Sure, I can start. So our program was at a place that's similar to Lori's OneGeneration at a Curry Senior Center, but they actually provide primary care, case management, and some recreation, senior center programming. And the people who, it's in a very low-income part of San Francisco in the Tenderloin neighborhood, so it's surrounded by single-room occupancy hotels where most of our patients that lived alone without caregivers lived. And so our navigator was actually able to do home visits to check on them. And in San Francisco, in California, there's an in-home supported services program for people on Medicaid that provides some in-home, care that's paid for by Medicaid. People without caregivers can't manage. Usually the recipient of care has to hire and manage their caregivers. So for people who live alone, San Francisco has a program called Homebridge, where the caregivers are kind of managed on their behalf. So our navigator would work with the Homebridge program and really, doing home visits to to try to get to know the person. I mean, I think it's really important for people who don't have an advocate, anything that you learn about them or observe about them and what their preferences and triggers are, that it's important to document that and communicate it with the team. And then helping with follow-up appointments, as Lori said, they don't have, that's another thing that family caregivers typically do. So most of them were receiving meal delivery programs and medication delivery programs. For the gentleman that was taking opioids, we got him in a pain treatment class so that there were more people monitoring his medications, as well as talking with the Homebridge caregivers around really trying to increase monitoring. Unfortunately, they weren't able to provide a caregiver every day. So, there's a lot of precarity, I would say, when trying to serve this population, because there are gaps that we're just not able to fill. And as Lori said, they're demonstrated with her case study, we're kind of dealing with what a family caregiver would typically deal with. So we had a client that lost his house keys, and we had to try to track down the landlord and get an extra set of keys. We had clients that would, their belongings would be stolen because they would forget to lock their door. And so, lots of problems that, are atypical, I would say. So needing to be creative and work as a team and collaborate with other service providers. I'm sure Lori has more to add.
Lori, do you want to add anything?
Sure. I think part of our complex case management services, we've really stepped in and done a lot of those services that a family caregiver would do. Like Sarah said, IHSS is in California, provides in-home supportive services. So how does a client get that? When the client is confused and demented, how can we help them? So we would help them fill out the paperwork. If their funding was if they had too much money, but it was just slightly over share of cost, we would help them to eliminate that share of cost through the client that I just presented. We helped with a very low-cost dental plan for him to eliminate that, and then we would also interview the care workers with the client. And when we talk about complex case management, a lot of times the caregivers, there would be a turnover. The client would think the caregiver was stealing from him, so we would get another caregiver. We would also, when we talk about creating a social service safety net, a lot of it is informal things, such as a neighbor. Maybe talking with the neighbor and seeing if they could kind of knock on the door, giving the neighbor our card, really knowing that we are available for people to call on us if they notice something that is different about the client. We also have, work with our utility companies who do wellness checks, and if they notice something, they alert our center. So it is trying to provide an infrastructure for them so they can stay home for as long as possible. And one thing I didn't add is that with our complex case management, even when our clients, if they do become institutionalized, we still continue to follow them while they're institutionalized so we can make sure that they get all the care they need, because especially our clients that do not have any family to help them. So I don't know if that added and answered that.
That was great. Thank you so much. Lori, can you talk a little bit about how, if you have a way to coordinate with primary care providers to let them know about the case management that you're doing with your clients?
Okay, so when it comes to the primary care providers, there's two ways. There's the back end where with our clients, once they received medical care, we would let all their doctors and people at the hospital know that this was the service that we provided. And we also went to our local hospitals and geriatricians and let them know that this was a service that we were providing to clients. So, for example, we have out here in California, Kaiser, and we went to their geriatric assessment units and said to all the doctors that this is what we're doing. If you have anybody that is homebound that you're concerned about, please refer them to us. So we really put it out there to all of our local doctors, to hospitals and to doctors and to emergency rooms, because a lot of these people are admitted through the emergency room, and to contact us as a way prior to discharge that we would be able to pick up the pieces.
Great, thank you. Sarah, anything to add?
No.
Okay. Can you talk a little bit about any collaborations either of you have had working with public mental health service providers to address mental health needs of people living with dementia? Or if you have your own mental health providers within your organizations and how you coordinate with them?
I will start with this because this is an area where I really am confounded that there's not more integration. Patients with dementia that don't have a primary mental illness are technically not eligible for a lot of mental health services. So, for example, San Francisco has an emergency mental health crisis team that will do home visits. But unfortunately, when our patients are in crisis and there are weapons or violence involved, they end up having to call 911 because the mental health crisis team won't respond to people with dementia because they don't have a primary mental illness. So I think there's a lot of disconnect. Also, our clients aren't eligible for acute hospitalization if they're having psychotic symptoms, but it's because of dementia, as a result of their dementia, as opposed to a mental illness. They're not able to get hospitalized. So I think, unfortunately, we have a pharmacist on our team that specializes in helping with medication management for this population. There's a geriatric psychiatrist on our team that I'm also able to consult with. So I guess my concern is more around when you are titrating medications for acute psychiatric symptoms, it can be helpful to have hospitalization for people with dementia as well as people with mental illness. And I understand that these settings are not, again, designed for people with dementia, similar to most healthcare settings, but I think that this is an area where the needs are similar enough where I think there could be more collaboration, and part of that is changing Medicare rules and reimbursement. So that's my answer.
Great, thank you. Go ahead, Lori, if you have anything to add.
Oh, okay, thank you. And through the LEAP team that we are involved with, we have a psychologist that is on staff there, and she has been amazing with us and has gone out to do capacity assessments and worked with our clients and gone on to home visits. That's just for our clients, so it's not really addressing the systemic problem, but it has really helped with our clients for her to go out and meet with them one-on-one and help us with direction and medication and what the next step should be with them.
Great, thank you so much. Well, we've reached the end of our hour together. I want to thank Sarah Dulaney and Lori Resnick for great presentations and providing all this excellent information for our participants. And for the participants, we really appreciate your attendance today at the National Alzheimer's and Dementia Resource Center webinar series. Please join us again for our next webinar on April 27th, which will focus on community health workers, a key support for people living with dementia and their caregivers. Registration information is on the ASA website. I'm going to turn it back to Betsy Dorsett for some final remarks.
Great, thank you so much. And thank you everyone for joining us today. If you'd like to claim CEUs for this event, you'll receive a follow-up email by the end of the business day that will contain a link to the CEU application. That email will also contain a link to today's slides. You'll have 60 days to claim CEUs for this event, and it will take 30 days from the date of your submission in order for us to process and issue your CE credit. Thanks everyone for joining us today. Have a great rest of your day.